Hello. First of all, myself, Dr. Rayees AK. I'm coming from Kannur only, basically from Kannur, Chalu, Mattanur. Actually, I'm a consultant in intensivist at BNH Kannur. First of all, thank you, IMA Kannur, for inviting me for this session. I know this is a festival season, all will be busy and they want to go fast. But as you all know, now the controversy is happening in the clinical practice that whether clinical skill or gadgets. Nowadays, artificial intelligence is coming. So whether clinical skill or gadgets, which is more important in clinical practice, that is a controversy, or everyone was having this doubt. Being from a general medicine background, I still believe in the importance of clinical skill. But I do want to tell you that some point of time, gadgets can help you, or your clinical skill, they can help your clinical finding, and also that can help you in a better patient care. And nowadays, I think this gadgets like ultrasound and advanced hemodynamic monitoring, all these things are slowly replacing our clinical skill. Even our palpation of pulse from the basics to the actually the ultrasound is slowly replacing our simple stethoscope slowly. So I think ABG is the game changer or the opening batsman in that scenario. ABG was the first actually came as a gadget, I think, other than the stethoscope. But still, ABG is having that importance. He's still a game changer or a lifesaver in ICU. For that, I want to actually this topic is just to show you some important, some beautiful scenario which ABG served as a lifesaver or a game changer. So my topic is ABG, a lifesaver in ICU. Overview of topic is introduction regarding the ABG analysis in a nutshell. I am not going into the details of ABG because that itself will take 2 hours or 3 hours. And regular routine uses of ABG in ICU. And today's highlight is special cases of some special cases that I want to show you. And some points. Okay, introduction of ABG. As you all know, Henderson and Hasselbeck invented bicarbonate buffer system and measured the first blood pH in 1923. There actually started, actually there won the our ABG. After that, John Severingus developed the first ABG machine, and after that, 1960 and 85 came all the advanced ABG machine. Nowadays, I think this is the one among the latest ABG which we are using in our ICU. And this is the printout of an ABG. I don't think it will be very clear for you, but you can see from the blood gas to electrolytes to all the metabolic parameters and co-oximetry finding. This is actually for our daily routine practice, we need all these parameters. I think most of us are well versed with all these things. Next, we will move on to the ABG analysis in a nutshell. I am not going into the detail of ABG analysis, but as you all know, ABG is measuring mainly pH, PCO2, and PO2. All the other things like bicarbonate, base, excess anion, all these are actually calculated values which using the with the algorithm, the machine is calculating the value. We need to give FiO2 from our side, which what oxygen we are giving to the patient. And from that, we can PF ratio, that is PA2 by FiO2 ratio. That is the first thing. Whenever we see an ABG, first we need to find out PF ratio. So PA2 by FiO2 ratio, normal is more than 300. And if it is less than 300, we can call it as hypoxia. So if there is hypoxia, we need to go to the AA gradient, alveolar arterial oxygen gradient, that we can find out from this equation. If the patient is in room air, the PA2 is 150 minus PaCO2 into 1.25. And any other, if you are giving an oxygen, then the equation is, there is a slow difference, small difference in the equation. From that, we can find out the arterial oxygen, and we can see the PaO2 in arterial oxygen in this thing, and alveolar oxygen we will get from this equation. And in that, from that, we can find out the alveolar arterial gradient. So what is the importance of this means, if there is a hypoxia from the PF ratio, we need to find out the AA gradient. And if the AA gradient is normal, then it is because of the alveolar hypoventilation or some problem with the lung pathology. Some lung pathology is causing the hypoxia. If the AA gradient is more, then there is VQ mismatch like pulmonary embolism or diffusion defect or right to left shunt, all those things. Okay. Anyway, I'm not going into the detail of all those things. And next, the second thing we will measure is pH. So normal, as you all know, it is 7.35, between 7.35 and 7.45. If it is less than 7.35, acidosis, more than 7.45, alkalosis, then we need to find out what is the primary pathology of that patient. Whether, if it is an acidosis, then whether it is a metabolic acidosis or a respiratory acidosis. If it is an alkalosis, it is a metabolic alkalosis or a respiratory alkalosis. So, how I think we don't need to discuss much about this. If it is a metabolic, if the pH is low, it is less than 3.5, then we need to go for the check the bicarbonate. So if the pH and bicarbonate are in the same line, that means pH is low, acidosis side, and bicarbonate is lower side, that means it is a metabolic acidosis. Then pH is higher, bicarbonate is also higher, then it is a metabolic alkalosis. Same way, pH is less, but the bicarbonate is not less. That means that is not a metabolic acidosis. Then we go to the respiratory side. That means pH is low, PCA2 is higher. That means it is a respiratory acidosis. And if the pH is high, but bicarbonate is not high, then we need to go to the PCO2 side. That is, if the PCO2 is low, then it is respiratory alkalosis. And finally, we are getting a primary pathology, whether it is a, so if you are getting a respiratory case, we need to find a respiratory, if we are getting a respiratory acidosis or primary pathology is respiratory acidosis, means we need to check whether it is an acute condition or a chronic condition, because our treatment differs from an acute patient presenting with an acute respiratory illness and a chronic respiratory illness. So that we can, in that history will help you, like a patient who is a non-COPD patient coming to you with a type 2 respiratory failure. It is not like, we are not going to treat the patient like a patient who is not having a history of COPD and presenting to you with a respiratory acidosis, with type 2 respiratory failure. Then we need to be bit more aggressive in treatment, like any intoxication of some chemical gas or something like that, or a central suppressant. Then the PCA2 is high. Then we need to intervene in a faster way. So if it is an acute case, then we can identify with the pH change and also with the bicarbonate change. That is, a patient is coming to with our, we all know that our PCO2 is less than 45 normally. And if the patient is coming to with a 80 PCO2, that means there is a change of 40. So we will divide it with the 10. So for every 10 rise of PCO2, there will be a pH change of 0.08. So if that patient is coming, to with a 90 PCO2, so his change will be like 9 multiplied by 0.08. So if the pH change is not that much, it is lesser than that value, then it will be a chronic. It may be a chronic condition. I think you understood that. And if the same way, if the patient, the PCO2 is 90, but the pH change is less than the 0.08, that is somewhere near, if it is multiplied by 0.03, then we can consider it as a chronic condition. And the treatment varies, because if a patient is coming to with a severe type 2 respiratory failure who is not having a history of PCO2, this thing, then we need to give all the mechanical ventilation or the other intervening things. We need to give it in a faster way. And next thing is renal compensation in respiratory cases. So we understood that this is a respiratory case, and there is a pH change, that also we understood, and we understood whether it is an acute case or a chronic case. Then we need to check whether it is compensated by the kidney. So we are measuring the renal compensation in respiratory case. That is a small formula or equation for that. Actually, for every 10 rise of PCO2, there will be 1 bicarbonate rise in acute respiratory acute condition. And in chronic condition, for every PCO2 rise, there will be rise of 4 bicarbonate. So from that also we can understand that whether it is an acute condition or a chronic condition. Like that, in respiratory alkalosis also, for every 10 PCO2 rise, there will be a rise of 2 bicarbonate. And for every 10 PCO2 rise, there will be a rise of 5 bicarbonate in a chronic respiratory alkalosis condition. In that way, we can understand whether it is an acute respiratory failure or a chronic respiratory. Next, we will move on to the metabolic case. So we know we have metabolic acidosis and metabolic alkalosis. So in that case, we need to find out whether it is compensated by the lung. So first thing is our pH should be in a normal range to make the patient hemostasis in a proper way. So for that, whether the body is able to maintain the pH by the corrective mechanism by using the lung or kidney, whether that is happening or not. That is our aim. And if it is not happening by the body, then we need to intervene it, and we need to use our gadgets or treatment or pharmacological therapy or non-pharmacological therapy to maintain the pH. That is our aim. So in any metabolic acidosis, the expected PCO2 range is 1.5 times the bicarbonate plus 8 plus or minus 2. And in metabolic alkalosis condition, expected PCO2 change is 0.7 multiplied by bicarbonate plus 20 plus or minus 5. So with this calculated formula, we can find out whether the body is equally compensating it, or in other way, we will get another clue that this patient is only having this respiratory condition, or at the same time, if a patient is coming to with a type 2 respiratory failure, at the same time, if the patient was taking some drugs like an acetosalamide, which is causing another metabolic change, that also we can find out from this formula. So if it is a metabolic acidosis, finally we reached the metabolic acidosis, we got a metabolic acidosis, then our aim is to differentiate whether it's a high anion gap metabolism, high anion gap metabolic acidosis, or a normal anion gap metabolic acidosis. Anion gap all must be knowing. I think it's unmeasured anion, sodium plus potassium minus chloride plus bicarbonate. Normal is between 8 and 12. So if it is a high, then metabolic acidosis with a high anion gap metabolic acidosis, we call HEMA. So the synonyms and everything, methanol, uremia, DKA, propylene glycol, isonium acid, lactic acidosis, all the toxins which causes metabolic acidosis with the high anion gap metabolic acidosis. And metabolic acidosis with the normal anion gap, that is diarrhea, renal tubular acidosis, the patient who are on total parenteral nutrition, drugs like acetosalamide. So with that, sometimes we will think a patient is type 2 respiratory failure coming to with low sensorial will be only having a type 2 respiratory failure with the respiratory acidosis. That may not be the thing. Sometimes there will be an additional pathology which is causing the clinical instability for that patient. That also we can identify from this formulas. And that I already told, mixed metabolic cases, there is also one more formula. We can calculate the delta ratio, and delta ratio, with that we can identify whether it's a pure normal anion gap or a mixed HEMA and NAGMA or a pure HEMA, that we can differentiate with this. I am not going into the details of calculation because it is a little bit complicated. I think it will take more time. So we have gone through the simple steps of ABG analysis. I think next we will move on to the routine ABG and daily ABG use in ICU. Okay. So there, as you all know, sepsis. Sepsis is the most important clinical scenario where we can use ABG from the diagnosis to the treatment management, from the initiation of treatment to the final from the discharge from the ICU. All point ABG is an important thing. From the diagnosis, we all know, according to the surviving sepsis guidelines, ABG should be taken within first 1 hour, and we should take the blood culture within first 1 hour, and we should give the IV fluids with 20 ml per kg, and we need to give the first shot of antibiotic, all with shooting, we should give within 1 hour. That is surviving sepsis guidelines. In that, lactate is the most important thing which will help us to diagnosis of the case and also the management of the case. And we can use lactate for for the resuscitation and deresuscitation also. Deresuscitation may be a new term. I think deresuscitation means immediately after giving the IV fluid, the next step is we de-escalate the giving the fluid. Usually, we older times actually we used to start IV fluid from the emergency medicine department, and we will continue 100 ml per hour fluid in all ICU patients for next 2 days or 3 days. Nowadays, the clinical scenario is changing, and all studies, recent studies are showing we need to de-escalate the fluid immediately after the first resuscitation. That is called a de-resuscitation. For that, we can use all the gadgets like point of care ultrasound. With that, we can measure the fluid status of that patient, and we need to de-escalate the IV fluid immediately after our goal point is achieved. That is mean arterial pressure of 65. Once we reach the mean arterial pressure of 65 and the patient clinical status starts improving, we need to de-escalate the IV fluid according to the hydration status of the patient. For that, in modern ICUs, we are using POCUS, point of care ultrasound, and bedside ultrasound. With that, we can measure the fluid status of the patient by checking the inferior vena cava fluid distension and all those measurements like cardiac output measurement, all those things. So with that, we need to de-escalate the fluid. In that, ABG helps in the main part of management and de-escalate treatment initiation and also the de-escalation. Lactate clearance we can use as a marker of improvement of the patient, and we can de-escalate. Respiratory case, first thing is ARDS. ARDS, we know diagnosis of ARDS along with the chest X-ray finding and the clinical history. ABG PF ratio is an important thing that is in the Berlin's criteria of diagnosis of ARDS. So PF ratio less than 300 means there is hypoxia and there is chest X-ray bilateral infiltrates within 2 weeks of duration. And there is no other pathology which we can identify. And if the cardiac status, wedge pressure is normal, then we can diagnose it as ARDS. That is the Berlin's criteria. And severity is also depends on the PF ratio. PF ratio means PF ratio is 300 to 200. That means mild. And if it is less than 100, then it is severe ARDS. And ABG is helping us for regular monitoring and ventilator adjustment according to the lung improvement, along with the other parameters like ventilator graphics and everything. And also for weaning from the mechanical ventilation also, ABG helps us. And respiratory failure, as you all know, COPD and acute severe bronchial asthma, indication and initiation of NIV, mechanical ventilation, all those things are based on the ABG and also the clinical condition of the patient. Improvement we can assess by the PCO2 clearance in type 2 respiratory failure. Tapering of ventilation support, weaning, ventilation support, tapering and weaning from the ventilator or BiPAP or NIV. That is also based on the ABG and also the clinical situation of the patient. And we can also help the patient for if the patient needs prolonged home BiPAP or home NIV. In that case, if the carbon dioxide is still persisting without NIV, the carbon dioxide is rising. Actually, from in the ICU, actually, all the times actually we shift the patient only when the patient is out of NIV. Now we are actually early shifting the patient to room with portable NIV. For that, we can change the continuous NIV to intermittent NIV. And intermittent NIV, with the intermittent NIV, the carbon dioxide is still rising. Then we need to give the prolonged oxygen therapy like LTOT, long-term oxygen therapy, or NIV at home. Renal failure, as you all know, metabolic acidosis as a guide in initiation of RRT and for regularization of RRT and monitoring of the improvement and worsening. And in toxicology, you all know, some toxicology case we can diagnose with ABG like ethanol, methanol, cyanide, all those things. And in that treatment initiation, optimization, and initiation of dialysis, initiation of mechanical ventilation, all we can done by the ABG. So hyperglycemic emergency, DKA, that is also, you know, with the high and metabolic acidosis itself, we can diagnose if the patient is having high sugar with the ketone positive. That is a diagnostic listing of DKA, and its monitoring, improvement, worsening, everything we can, the ABG will help you. So these are the routine cases of ABG which we are using in our daily practice. And from this, I can definitely tell you ABG is an important pillar of any ICU, along with the other gadgets like point of care ultrasound, chest X-ray, CT, MRI. ABG is still an important player of ICU management. This is now we move on to the some special scenarios. This is the highlight of today's topic. From this scenarios, we have 7 scenarios. From this scenario, I wanted to tell you all that ABG is a very important thing. At some point of time, ABG will help you. ABG will act as a game changer. One is a case of malaria. Actually, it was a referred case when I was working at Calicut BMH. A 28-year-old male coming back from North India. He was diagnosed with the falciparum malaria with the features of complicated malaria, with the creatinine was borderline high, bilirubin was high. He was having high-grade fever with the borderline complicated malaria. He was started on anti-malarial treatment with which was having anti-malarial treatment with the Primakin combination from the North India. And he was actually came after 3 days of treatment to our this thing because he was from Calicut. And the 4th day or 5th day, he developed actually hypoxia. 2nd day of coming back to Kerala, he developed a sudden hypoxia. So all were worried about whether the patient is going for an ARDS or this thing. But his X-ray was completely normal. He was having severe hypoxia with a 10-liter oxygen, 15-liter oxygen. He was having severe hypoxia. Ultrasound was normal, no pleural effusion, no cardiac involvement, nothing. Chest X-ray was normal. So what is the cause? So we did the ABG. ABG, pH was normal, PCO2 was normal, calcium was normal, everything was normal. But the methemoglobin, as I already told you, our first ABG was showing a co-oximetry measurement. In that, methemoglobin was 18%. So it was a case of methemoglobinemia caused by the Primakin. So we stopped the Primakin and changed to doxycycline regimen, and we treated with methylene blue and vitamin C. So with that, with the help of that ABG and co-oximetry value, we could avoid the ventilation and NIV, all those things. And with the methylene blue and vitamin C, the patient saturation improved within 48 hours, and the patient shifted to room after 48 hours of management. Next is a case of RTA. This happened very recently, 2 months back in BMH Kannur. So a 45-year-old male presented with the RTA with the pelvic injury, something like an auto rickshaw accident. And initial ultrasound showed free fluid, and CT showed pelvic hematoma with he was having severe hypotension and hemoglobin fault. Emergency, actually, because of the pelvic open fracture and bleeding, emergency pelvic packing done in the OT, and the hemoglobin stabilized, BP improved, and patient clinical status improved, and patient shifted to ICU. But after 6 hours of ICU shifting, the patient developed a severe respiratory distress. The ventilator showing a severe respiratory asynchrony, and the patient is having severe tachypnea. We evaluated the case. The chest X-ray was within normal limits. Point of care ultrasound was not showing any increase in hematoma or a new hematoma. No bleeding. And chest X-ray, everything was normal. So we, as usual, when in doubt, take an ABG. That is intensivist dictum. So we took ABG. ABG was otherwise normal, but lactate was a little bit higher side. It was 4.6. So we don't know. We again sedated and paralyzed in view of severe asynchrony. Patient condition was started worsening immediately after giving the sedation and the paralysis. BP was falling. So repeat HB was stable, but we usually think it is because of the bleeding, but hemoglobin was stable. Sepsis was unlikely because everything happened in 12 hours. So sepsis was unlikely. So we did the serial ABG. ABG was showing lactate 4.6, 6.5, 9.3, and 10.4. Patient again re-evaluated. So in view of severe lactic acidosis, a local tissue hypoperfusion was suspected, and a mesenteric ischemia or any other local ischemia was suspected. And we did the CECT abdomen that was showing edema or hematoma of the ileocolic junction, maybe an old hematoma which is there. So we immediately taken for lab evaluation. There was actually, now I can say, retrospectively, I can say in a very simple manner, but there was so much of confusion happened for taking the patient to OT for re-evaluation laparoscopy. But finally, because of the increasing rise in this thing and BP fall, we taken this thing. And it was showing a hematoma on the ileocolic junction, which was compressing and causing a relative ischemia. And that ileocolic area was having actually ischemic changes with the color change of the bowel. Immediately with the laparoscopy, we removed the hematoma. Post-op ABG showed a resolving lactate level. Next day, patient lactate became 4.6, then 2.1 and normalized, and the patient status improved. Next is the third case. Third case is a 60-year-old female presented in emergency with a severe shock. This happened in another hospital in Kannur. Actually at Srichand Hospital. And with no comorbidities, patient presented with a severe shock. BP was 70/40. Patient was in severe septic shock. I mean, in severe respiratory distress. BP was 70/40. Actually, patient was not having any history of fever, no altered sensorium, nothing. But now patient presented with a loss of consciousness and hypotension. So we initiated inotropes. Patient was mechanical ventilated because of the LOC, and along with that, we initiated antibiotic as per the sepsis protocol which we are having in our emergency department. But her total counts came 18,000. CRP was not very high. Procalcitonin was negative. Creatinine was borderline high. OTPT was borderline high. Chest X-ray normal. USG normal. MRI brain normal. Sugar normal. So nothing was there to tell you that this is the cause of this loss of consciousness and hypotension. So usually, as usual, we did the ABG. ABG was showing severe metabolic acidosis. pH is 6.98 and bicarbonate was 8.2. So we searched what could be the cause, and her anion gap was 26. So what can be the cause? Severe high anion gap metabolic acidosis. Patient was re-evaluated. No sepsis. CRP, procalcitonin, all were not very high. No renal failure history, no CKD history, sugars normal, no DKA. Then what? So we again gone through our cat mud piles, our keywords of high anion gap metabolic acidosis. We ruled out diabetic ketoacidosis, alcohol starvation, all those things we rolled out. Then comes the toxicology part. So we again gone back to bystanders and taken history again and asked them to search that area. And they came with a half empty bottle of sanitizer. And that content was actually, that was an Ayurvedic sanitizer. And that content was something like Prasanna. We searched in the Google, that was showing 69% rectified spirit, that ethanol. And so we taken it as an ethanol toxicity. Initially, we treated with the bicarbonate, thiamine, and all the supportive measures like an ethanol toxicity. But she was having resistant acidosis, hence taken for dialysis, because that itself is a treatment for ethanol toxicity also. So actually, luckily, patient improved very well with the hemodialysis, and patient sensorium gradually improved, hemodynamics improved, and being off from the ventilator, and patient extubated on the 4th day of this thing treatment. Next was, this case happened at Calicut. Actually, there one patient was referred from a peripheral hospital with loss of consciousness, altered sensorium and drowsiness. Outside CT, MRI, both were negative. Sugars normal, counts normal, CRP, procalcitonin was normal. No unilateral or any deficit other than the altered sensorium and drowsiness. So everything was normal. Before the LP, we usually, intensivists usually take the ABG. If we are in doubt, take an ABG. That is our dictum. So we took the ABG. So otherwise pH was normal, bicarbonate was negative, normal, lactate was negative. But the ionic calcium, you can see the ionic calcium was showing 1.45. So we repeated the serum calcium. That was 14.6. ESR was high. So that was a metabolic encephalopathy caused by hypercalcemia. So later the diagnosis revealed that was a case of multiple myeloma with severe hypercalcemia and metabolic encephalopathy. So we treated with anti-hypercalcemic measures like calcitonin, ibandronate, everything, and patient improved. So in this case, it is not because of the ABG. It is because of the newer ABGs having all the parameters like electrolytes, and all the co-oximetry, all these things, not directly because of the blood gas analysis, but because of the newer ABG. So that itself says we can use ABG in a different way also if we need to improve our clinical result. Then another case, a renal case, a 53-year-old female presented with, actually she's a baseline CKD with the baseline creatinine of 3.6. She was presented in severe tiredness. She was in hypotension. Actually, she was brought by the neighbor with an inadequate history. So her initial evaluation was showing creatinine of 11.3, urea was 220, potassium was 4, and she was in severe oliguria. In ED, last 2 hours, only 10 ml came. And the ED resident, as usual, informed the consultant that pH is very bad and patient's creatinine is 11 and hemodialysis planned because of thinking it is because of the worsening of the acute on chronic renal failure. But we took the ABG. ABG pH, yes, like the resident told, it was 7.01. Bicarbonate was 9.2. But when we calculate the anion gap, it was just 12. So it is a normal anion gap metabolic acidosis. So what can be the cause of normal anion gap metabolic acidosis in such a setting? So we gone back through the mnemonic. So non-anion gap metabolic acidosis or a normal anion gap metabolic acidosis, always gut will be the cause. Gut is the first cause. So we taken the history and we did the USC with hydration status, and 2D echo was showing severe dehydration, the collapsed IVC. So that was actually a diarrhea case with a normal anion gap metabolic acidosis. So patient was initially treated with IV fluids, electrolyte correction, and initiation of a proper nutrition. Her hemodynamics improved, output improved, gradually ABG also improved, and creatinine improved from 11.6 to 6.2 with the adequate output in 48 hours. So we could avoid the dialysis in that fitting because that was a normal anion gap metabolic acidosis, not a high anion gap metabolic acidosis in a case of, just like a case of normal renal failure or other scenarios like a sepsis. Another case is a hemodialysis patient was referred from a peripheral hemodialysis center. Like a normal pure hemodialysis center. So that patient was referred with severe hypoxia during dialysis. So patient was on NIV and he was on actually 15 liters of oxygen like that. And he was on high oxygen NIV support by considering pulmonary edema. Usually during the dialysis, if a patient is having severe hypoxia, we usually think of cardiac origin or a pulmonary edema. So mechanical ventilation was planned in view of severe hypoxia. But again, that was a methemoglobinemia. So the methemoglobin percentage was 34%. So what can be the cause of methemoglobinemia in a case of hemodialysis? So we gone back to the medications like any other medication which is causing methemoglobinemia. Nothing was there. So we searched the internet for methemoglobinemia causing during dialysis. So that was showing a doubtful chemical, that chloramine. So that is actually in the chlorination of our dialysis fluid, not because improper mixing of the fluid, improper sterilization of, they are adding more chlorine and chloramine to the solution of dialysis fluid. So that chloramine, so multiple literatures are telling the same history as in the UK, USA, everywhere. So we taken it as a chloramine toxicity and methemoglobinemia. And we avoided this thing, ventilation, because we searched the other causes also. Ultrasound was normal, chest X-ray was normal, LV was normal, cardiac status was normal. So we taken it as a case of chloramine toxicity and we treated with the methylene blue and vitamin C. So patient gradually improved, and without mechanical ventilation and everything, patient improved, and we could avoid the mechanical ventilation in that setting. Another case, 7th case, it was actually a bone and soft tissue infection. This is a normal case. Actually, a 62-year-old male presented with very high blood sugars and drowsiness. He was having severe decay. Sugars were 620, severe high anion gap metabolic acidosis with 1.6 of bicarbonate. Patient was initiated on DK protocol, insulin infusion, IV fluids, bicarbonate, antibiotics, everything was given. Initially, he showed some improvement in this thing, but still his ABG was not improving. ABG was having still persistent high anion gap metabolic acidosis. So we reevaluated the case. So we taken back the history. He was having severe knee joint pain. So we evaluated with our orthopedician. So we took an MRI knee joint, and it was showing pus collection with osteomyelitis. So it was not because of just a DKA because of skipping of insulin. It was an osteomyelitis which caused the hyperglycemia and precipitation of DKA. So we treated, arthroscopy done, and pus aspiration and drainage was done. Antibiotics continued. That was later diagnosed as an MRSA with this thing, osteomyelitis. And patient DKA improved, insulin tapered and stopped, and patient improved. So these scenarios actually indirectly says at some point of time when you are in doubt or in a particular point where our clinical skill or a clinical scenario, when we have a doubt, at that point ABG can help you. Still ABG can help you. ABG with our other gadgets like echo machine or a point of care ultrasound or ultrasound machine or advanced hemodynamic monitoring, all this can help you during the management of an ill patient in our ICU. So ABG is still a game changer. From I already told you, from 1962, even in 2023, ABG is still a game changer. So our dictum is take the ABG, read carefully and systematically from PH to the base axis. We need to, actually we used to tick all the points and read when in doubt. When we are in a doubt clinical situation, we will tick the ABG. Okay, pH is normal, calcium is normal, sodium is normal, potassium is normal, bicarbonate is normal, anion gap we will measure whether there is any compensation is happening or not. That like that in a systematic way we usually go. And some point of time ABG will help you. That was our experience. ABG can augment our clinical finding. Gadgets can do wonders in clinical practice. We should admit the fact that even if we say clinical skills are superior, but gadgets can still do wonders in clinical practice. When in doubt, take an ABG and read carefully. Thank you.
Thank you very much for the presentation and very good presentation. Now you have this all answers. Is BKR or EPR? But it usually is ethanol is not with the no, it's that's the one that's going to the whole campus, both are same this morning, but in case of ethanol, because usually both of us, even ethanol is most severe and everybody is just like and even cause this much more taking almost content about take almost half. And then one of the scenarios carbon monoxide. Sometimes there will be oxygen gap. Usually construction will be shown a normal but if you do an ABG, you will show hypoxemia, and carbon monoxide. Another scenario is to find this 100 volts. So you can see that hypoxia and the AK, it is usually done on the box. Even carbon monoxide, sometimes they will be normal unconscious. They will do consumption, they will be normal. But if you do AV, you find carbon oxygen oxygen and on the actually only oxygen. With the bonus period, bonus period
We can treat treatment for we can go for immediate mechanical our and we can our sincere thanks to Dr. Rayees AK for his excellent and informative talk on ABG. Thank you, Doctor. Also, thank all members for attending today's meeting.
No,